Picture this. It's 2 a.m. You're in the ICU, and your patient is absolutely crashing. They're severely thrombocytopenic, they're showing clear signs of acute microangiopathic hemolytic anemia, and their mental status is just rapidly deteriorating from widespread organ ischemia. You know it's immune thrombotic thrombocytopenic purpura, good old ITT. You've ordered therapeutic plasma exchange, but the standard, textbook treatments, they are failing to stabilize this patient fast enough. And every single minute that passes means more microthrombi showering their brain, their heart, and their kidneys. When the standard interventions just aren't enough to pull a patient back from the brink, you need immediate, highly targeted therapy.
Okay, let's dive into this. What do you actually do when you're standing right there at the bedside, and that sense of panic starts to creep in because plasma exchange isn't turning things around quickly enough? Well, you have to pivot. We can no longer rely solely on the traditional methods of just trying to, wash out the bad plasma. We're now in an era of highly targeted, modern pharmacological therapies that can literally stop this disease process in its tracks. In today's Explainer, we're going to look at the absolute cutting edge of critical care hematology and how a combination of targeted biologics has completely rewritten the standard of care for iTTP. To really understand why we need to be so aggressive, just look at this number. Greater than 90%, actually no, literally over 90%. That is the mortality rate for iTTP if we leave it untreated. Without prompt and proper intervention, this is a universally fatal disease. And even with historical treatments, the burden of morbidity, we're talking the long-term neurological damage, the cardiovascular events, it remains incredibly high. These are absolute life or death stakes, which is exactly why getting the pharmacology right now, is not just some academic exercise. It's a matter of survival. Let's rapidly break down the microscopic pathophysiology, because truly understanding the mechanism is how you're going to remember the treatment. Step 1. Your patient's immune system goes rogue and produces autoantibodies that inhibit or clear out ADAMTS13, which is a crucial metalloprotease enzyme. Step 2. Without that ADAMTS13, ultra-large multimers of von Willebrand factor, or VWF, start accumulating in the bloodstream. Step 3. These sticky, ultra-large VWF multimers act basically like flypaper, causing platelets to clump together into microscopic clots, or microthrombi. And finally, Step 4. These clots block small arterioles and capillaries, leading to widespread end-organ ischemia. The platelets are all getting chewed up in these clots, which is exactly why your patient is severely thrombocytopenic and bleeding while they are simultaneously clotting off their organs. And this brilliantly illustrates how we attack that exact pathophysiology. To save this crashing patient, we have to deploy two incredibly targeted weapons that work synergistically. I want you to think of Caplacizumab as the shield, and Rituximab as the source control. One acts instantly to protect the patient from the immediate life-threatening danger, while the other goes deep to shut down the factory that's actually producing the disease. Let's look at exactly how each of these works to turn the tide in the ICU. Part 1. Caplacizumab, the immediate shield. So Caplacizumab is quite literally your shield. Pharmacologically, we're talking about an anti-VWF nanobody. It hones right in and physically binds to the A1 domain of the von Willebrand factor. And why does that specific spot matter? Because the A1 domain is exactly where platelets attempt to attach. By physically blocking that interaction, Caplacizumab immediately halts platelet adhesion to those ultra-large VWF multimers. It stops downstream microthrombus formation right in its tracks. So while you're waiting for other therapies to clear out those autoantibodies, Caplacizumab shields the patient's organs from further ischemic damage and allows their platelet counts to normalize rapidly. Just how powerful is this shield? Well, the number needed to treat is just 35 to prevent one single death. That's a massive clinical impact for an ICU intervention. Data from the International Caplaf 1000 Plus project, which looked at well over 1,000 patients, showed a staggering 98.5% 3-month survival rate when Caplacizumab was used. Plus, patients receiving this nanobody showed reduced refractoriness, fewer exacerbations, and they required significantly fewer plasma exchange sessions to achieve a clinical response. It just drastically alleviates the overall burden of care. Which brings us to part 2, Rituximab, the source control. Now, what's really interesting about this is that while Caplacizumab buys you crucial time, it definitely doesn't cure the disease. For that, we need true source control. Rituximab treats the root cause. It's a monoclonal antibody targeting the CD20 antigen right on the surface of B cells. By systematically depleting these B cells, Rituximab halts the production of those anti-ADMTS13 autoantibodies. It literally shuts down the autoimmune factory.
This is what allows the patient's own ADMTS13 activity to eventually recover, and it prevents the disease from just roaring back the second you stop plasma exchange.
And the data backing up rituximab as source control is just as striking. The number needed to treat with rituximab? It's an incredibly low 3.3 to prevent a single disease relapse. Let that sink in for a second. By giving this medication early and even shortening the interval to every 3 to 4 days during concurrent plasma exchange to compensate for the drug literally getting washed out, you're drastically accelerating platelet recovery. More importantly, you're profoundly reducing the chances that this exact patient will end up back in your ICU months or years down the line. So, when we bring this all together into what guidelines now call triple therapy, you can see the perfect synergy in action. It's like a perfectly timed orchestra. This timeline shows how the staggered effects of these therapies overlap to save the patient. In a matter of hours, Caplacizumab is on board, acting as the shield, blocking new clots and protecting the organs. Over the next few days, therapeutic plasma exchange, or TPE, is actively removing the existing autoantibodies from the blood and replacing the missing ADAMTS13 enzyme. And then, over the course of weeks, rituximab acts as the source control, stopping the production of any new autoantibodies. This combined multi-pronged attack, it's exactly what has transformed iTTP from a near-certain death sentence into a highly manageable condition.
Moving on to part 3, high-yield clinical pearls and pitfalls.
So the crucial point is this. Knowing the pharmacology is great, but avoiding fatal mistakes in the heat of the moment is what actually makes you an expert clinician. Here are your absolute do-nots. First, you must initiate TPE within 4 to 8 hours of diagnosis. Delays drastically increase mortality. Second, and please remember this fatal trap, never give prophylactic platelets. I repeat, never. Unless there's literally life-threatening bleeding, giving platelets to an iTTP patient is like throwing gasoline on a fire. You are actively feeding the microthrombi. Third, do not wait for the ADMTC13 lab results to come back before starting TPE. Send the lab off, use your clinical scoring systems like the Plasmic score, and treat immediately. And finally, always screen for hepatitis B before administering rituximab, because reactivation can be deadly. To summarize the landscape, we have to balance the risks. TPE clears the autoantibodies, but it comes with massive logistical headaches and the infection risks of a central venous catheter. Plus, you're exposing them to donor plasma. Caplacizumab blocks platelet adhesion brilliantly, but its main risk is bleeding, which is reported in about 11% of patients in trials. However, let's be real, this bleeding is generally manageable and pales in comparison to the utter devastation of untreated iTTP. Finally, rituximab depletes B cells, which carries risks of immunosuppression, systematic infections, and hepatitis B reactivation. You have to weigh these risks, but always remember, the disease itself is by far the biggest threat in the room. Let's look ahead to part 4, the TPE-Free future. Here's a highly provocative question that researchers are asking right now. Could the sheer power of Caplacizumab and rituximab make central lines and therapeutic plasma exchange completely obsolete? We're actually already seeing emerging case reports, retrospective studies, and active clinical trials exploring the management of acute iTTP using just targeted biologics and steroids, intentionally omitting the plasma exchange altogether. The potential upside to a TPE-free approach is absolutely massive. By relying solely on the shield of Caplacizumab and the source control of rituximab, we completely avoid the major risks associated with central venous catheters. We eliminate the patient's exposure to large volumes of donor plasma, knocking out the risks of anaphylaxis and transfusion reactions. We drastically reduce the length of ICU stays and the intense round-the-clock burden on nursing staff and blood banks. And remarkably, case series are showing that patients can still achieve rapid platelet normalization and a sustained clinical response with these targeted biologics alone. This combination is already changing the standard of care, and honestly, it might seem redefine it entirely.
So I'm going to leave you with this final thought. What are you going to do the next time that pager goes off at 2 a.m. and the ICU calls with a crashing iTTP patient? Are you going to rely solely on the old ways, or will you immediately deploy the synergistic power of the shield and the source control? Understanding these targeted therapies isn't just about acing a board exam, it's about having the exact right tools to pull a patient back from the brink when every single second counts. Stay sharp, stay focused, and use the science to save lives.